Hello and welcome to Chapter 14. I am Miss White, and today we'll be talking about altered reproductive function in the male and the female. On this slide, this is just an overview of the female reproductive structures. Just note where uterus are and the ovaries, as that's where most of our hormones are going to be focused on. And again, this is just an overview of the internal reproductive structures and the external genitalia. So as far as the female reproductive function, it's heavily based on hormones. So in one of your recent chapters, you talked a lot about the pituitary and the hypothalamus and how they secrete different hormones to affect different parts of the body. Well, we have the pituitary also controlling hormones that are targeted for female reproductive system. So those hormones are actually listed on this slide. You see estrogen, which comes in three formats. You have estrone, estradiol, and estriol. These are noted as E1, E2, and E3 respectively, and they are the primary female hormones. Then we'll move on to progesterone. Progesterone is a female sex hormone, but this one particularly prepares the lining of your uterus for pregnancy, and it also supports the body if there's a pregnancy allotted. Then we have prolactin, which allows lactation during and after pregnancy to occur. And of course, this is based off of a negative feedback system. So the more that there's stimulation for milk per the baby or the infant, the more prolactin that is produced, and thus it has this feedback system that continues to go. Now we have oxytocin, and this is one that works similar to prolactin. And prolactin, again, stimulates lactation. Well, oxytocin also stimulates milk ejection and lactation. But another important function of oxytocin is that it stimulates the contractions during active labor. So more oxytocin is produced as the labor is occurring and progresses until that infant is born out of the womb. The next one we'll talk about is human chorionic gonadotropic hormone, and this is known as HCG, and this is normally the hormone that is detected in urine when a mother is pregnant. So levels of this is detected within the urine, and elevated levels indicate that there is an active pregnancy, whereas low levels indicate that there is no pregnancy at all. The next one we'll talk about is androgens, and this is a precursor hormone. Now, you'll see androgens a lot in terms of testosterone and in terms of female hormone function. Now, androgen does not necessarily turn into testosterone in females because, that's more of a male hormone, but it's just good to know that this is a precursor hormone that females also produce. So here's just an overview of ovulation. So as you know, ovulation is the process by which there is an egg release from an ovary, either the left side or the right side, into the uterus in hopes of it being impregnated with a sperm that would then develop into a fetus and ultimately an infant after pregnancy. So in order for ovulation to happen, you have to have a couple of phases that go through this process. So the first phase is the follicular phase, and I'm not going to ask you to necessarily remember the primordial follicles or the secondary follicle or atrophic follicles. We're not necessarily going into that detail, but what I want you to know is that the follicular phase is the phase that occurs with the egg that is the before the release of the egg into the ovary. And then this phase is really more closely associated with estrogen. So as the follicular phase is occurring during the first 14 days after menstruation happens, we see more elevated levels of estrogen in the female body. Versus when ovulation happens, those estrogen levels start to fall, and then we move into the luteal phase. Now, the luteal phase is where that ovulation has been completed, and now we are at the phase that this is after the release of the egg. When we discuss the luteal phase, this is after that 14-day period. So this is days 14 through 28 when the body is then preparing to have menstruation again, because it no longer needs those contents in the uterus to help sustain a pregnancy. So the luteal phase is more closely associated with progesterone. So the key point here is that as the follicular phase phase goes on, estrogen levels are elevated. As that follicular phase decreases during that 14-day period, we see it increase, and then progesterone, which is more closely associated with the luteal phase, during days 14 through 28. And it goes on and so forth. And this is why we have menstruation, because once ovulation occurs, if that egg is not fertilized by a sperm, then that egg is disintegrated essentially, and it falls with the contents of the uterus as it's extracting with the menstruation. So now we are talking about the actual uterus in this point. We're talking about the endometrium, and this is the tissues that line the uterus or the womb, or this, you can actually call this a mucous membrane, and it does thickens if the body is anticipating a pregnancy, and it does not stay there. This is why we have menstruation. So it thickens if there's an anticipated pregnancy, but then if the pregnancy is not sustained or there's no fertilization of that egg, we see menstruation, and that lining or the endometrium sheds, and this is what we call the menstruation. So when we talk about endometrial growth, this is specific to the uterus. Now, there are different phases that we see with the uterus. We see the proliferative phase, the secretory phase, and then the menstrual phase. So do not get this confused with the actual phases of luteal phase or the follicular phase. When we talk about that, that's actually the oocyte, or the pituitary cycle that we're discussing with that. Okay, so with the proliferative phase, we're talking about the endometrium, the uterus, and when we talk about this, this is actually the end of menstruation to ovulation. So when we talk about proliferative, you can think about this is where the endometrium or the uterus is starting to thicken. So this normally occurs around days 4 through 14. Or 5 through 14. It depends on each female's menstrual cycle, of course, but that's around the average where we see the proliferative phase. So with the proliferative phase, we see a decrease in estrogen levels as the uterus thickens. But think about this. We are having the egg migrate to the uterus at the same time that the uterus is thickening, because the body is preparing for a pregnancy to be sustained. So those estrogen levels are going to fall, because this also occurs during the same phase as your follicular phase. So we have the egg that's migrating to the uterus. We have the uterus at the same time that is thickening, that will hopefully sustain that pregnancy. But then if it does not, then that's when we see a decrease, and we'll move on to the next phase with that. So the next phase is that we see the secretory phase. So this is at the point of ovulation, and the egg has actually dropped inside of the uterus. So now this is the phase where if the female has sex and there's sperm that fertilizes the egg, at this point you would be most fertile, because you have the egg in exactly the place that it needs to be fertilized. So if this does not occur, of course, if the fertilization does not occur, then we start seeing the breakdown of that endometrium. So this is where we start seeing the decrease in our thickening of the uterus. So you can call this technically the start of menstruation, because it has to break down in order for menstruation to occur. So then we have the menstrual phase, which is the actual shedding of that uteral or endometrial layer. So this is at that cycle where the uterus is now broken down enough for it to start extracting the contents from the womb in order for us to start this cycle again. So this is happening at the same time as the luteal phase. So think about what's happening here. The follicular phase is happening at the same time as the proliferative phase. Follicular phase of the oocyte is happening at the same time as the proliferative phase of the uterus. Then we have the luteal phase, which is where that egg is not being fertilized. So now the uterus is starting to break down. So again, the progesterone is at higher levels at this particular point of the phase because estrogen levels have fallen at this point. So once we have this process occur, again, we see menstruation. So just make sure you don't confuse proliferative phase with the secretory phase, with follicular phase and the luteal phase, because they're talking about two different areas in the body, but they do happen in tandem and they do happen at the same time. So next we'll talk about the male reproductive function, and this is just a brief overview. Just make sure you're understanding that most of the hormones that we're talking about is going to affect the testes and more oftentimes than not the erection cycle within the male. So the main hormone that I want you to understand with the male is testosterone, and testosterone has a lot of functions within the male. It's responsible for the development and the function of the reproductive organs. It's responsible for muscle mass production, skin thickness, sebaceous gland activity. It's also responsible for the growth of pubic hair, chest hair, facial hair, even the maturation of the voice box or the larynx, resulting in a deeper voice or a deeper tone in males. The gonadotropin releasing hormone and follicular stimulating hormone, luteinizing hormone, all of those act in tandem to help release testosterone, particularly to help with male reproduction. So we have different ways that we can alter reproductive function, and this can happen in males and females. So you have hormonal imbalances. I've talked about a couple of hormones already. We've talked about estrogen and progesterone, which is more present in females, and then we talked about testosterone, which is more prevalent in males. So if we have imbalances in even those hormones, we can see alterations in reproductive function, even in the development of those reproductive hormones. Reproductive function. We can see motility impairment, and we can also see immune problems as a result of altered reproductive function. As far as our manifestations of altered reproduction, you have infertility, which is a direct result of hormone alterations. You may have irregular menstrual periods, and that's directly related to progesterone and estrogen irregularities. You may have amenorrhea, where you're not producing estrogen or progesterone at all, and then it's causing you not to menstruate. So that's what amenorrhea is, absent menstrual periods. Or you may have anovulation, which is the absence of ovulation. And again, that's directly related to that, to the progesterone and estrogen levels you have. You may have pain, which is noted as dysmenorrhea or dyspareunia. And then you have endometriosis, which is an issue with your uterus. So these are general manifestations that you would see with altered reproduction function. So there are different ways that you diagnose altered reproductive function. Of course, you have to have a history and physical examination, but specifically you want to look at cervical mucus changes. There may be basal body temperature changes during ovulation. You may have specialized diagnostic tests which would look at your ovulation specifically or your semen analysis, and they may also look at the patency of your reproductive structures. In order to treat altered reproductive function, you may see some pharmacological methods. One specifically is clomiphene citrate, and this is a medication that is used to induce ovulation in those that may not ovulate very well. You may also see antibiotics to treat infection, or you may even see additional hormonal therapy to replace hormones that individuals do not have. To help supplement those body and metabolistic processes. You may have surgeries to remove obstructions. You normally see this with leiomyomas, or these are actually types of fibroids. So with fibroids, you have to remove those surgically in order for them to stop affecting the individual. So those fibroids are also considered leiomyomas. You may need supportive counseling and education because infertility is a sensitive topic, and sometimes in tandem with therapy, if therapy is successful or unsuccessful, it's good to have supportive counseling to help those clients through those situations, and also helping to educate the client in what to expect and what not to expect will also help with the mental state and in dealing with the psychological issues that come with infertility. As far as your reproductive technologies, you may have in vitro fertilization or artificial insemination that would help those that may have a partner that's unable to produce semen, or the partner that's unable to help with fertilization. So we have all types of treatment therapies that will help with altered reproductive function. So here's our application of the concepts of altered reproductive function. These are our syndromes or diseases. So feel free to take out your syndrome disease cards and fill these out as we're talking about these in the lecture. Okay, so this disease is called pelvic inflammatory disease, or PID, and it's normally the result of sexually transmitted infections, or STDs, STIs, of the reproductive tract. So you'll see inflammation, you'll see the immune response activated as a result of this PID, and normally your fallopian tubes are obstructed with drainage or purulent exudate, or this is pus, and sometimes you have scar formation in those fallopian tubes in the reproductive tract. As far as your diagnostic criteria, of course, you have to have a history and physical examination. Normally, there's a laparoscopy, which is just the incision where it's kind of like a biopsy where they look inside where the issues are. You have lower abdominal tenderness, neck sole tenderness, and cervical motion tenderness. As far as your laboratory studies, of course, if there's inflammation or immune response involved, you want to pull erythrocyte sedimentation rate, or CRP, and there may be a sexually transmitted infection screening that will screen you for everything that ranges from gonorrhea, chlamydia, anything that is considered a sexually transmitted disease, BV, trichomoniasis, any of those infections they would screen you for that would directly result in pelvic inflammatory disease. So again, PID happens secondary to some sort of sexually transmitted disease. So in order to treat, they would need to find out which disease or which organism is infecting the area, and that way they can treat it. And normally that's with oral or IV antibiotics. Normally you treat the pain. And if there is a high risk population, such as an individual that's immunodeficient, chronic illness, pregnant, then they'll hospitalize that individual because they can quickly go septic with an infection that severe. And here are our clinical manifestations. Of course, you have fever and malaise. That's your generalized weakness. Purulent cervical discharge, exudate. You have pelvic and lower abdominal pain, cervical tenderness, and sometimes you are asymptomatic in the early stages. The next one we have is polycystic ovarian syndrome, PCOS, and this is a condition of excess androgen production from the ovaries. Sometimes we do not really know what the cause is. It can be genetic, it could be environmental. There's multiple layers that are involved with that, so we can call this multifactorial or even idiopathic because there is no exact known cause for polycystic ovarian syndrome. You'll see anovulation, or the lack of ovulation, due to lack of follicular maturation. And normally you see cystic ovaries that are preventing ovulation because there's no space for those eggs to drop, and they're scarred. So you do see a relationship between high androgen levels and insulin resistance with PCOS. As far as your diagnostic criteria, you have to look at the Endocrine Society diagnostic criteria, and you have to have at least two of the following issues: either androgen excess, ovulatory dysfunction, or polycystic ovaries. Normally they'll do a hormone analysis, and normally they'll do an ovarian ultrasound to confirm if there's dysfunction or polycyst, or the cysts within those areas. As far as treatment, you have to have medications that suppress androgen production, such as birth control pills. You have anti-estrogen medications that help induce ovulation to achieve pregnancy. Again, progesterone is more associated with the actual pregnancy than estrogen. Progesterone helps promote pregnancy once it occurs. So you want to have anti-estrogen. That way you can promote the levels of progesterone to help with the pregnancy. You may have metformin prescribed to lower insulin, and it also helps to improve ovulation. They may do laparoscopic surgery to remove those cysts from the ovaries, and of course you want to treat the symptoms of pain and malaise and fatigue. The manifestations of PCOS includes menstrual irregularities, obesity, acanthosis nigrans, or this is known as darkened skin, and with excess androgen production, you may see hirsutism, acne, and male pattern baldness. So next we'll talk about ovarian cancer, and we do have a chapter that's focused on cancer, so I'll talk about a little bit of the pathophysiology, but it's very similar to that of most cancers, where we have cells that are not being that are not working very well, and they either overproliferate or overdifferentiate, causing in the area that is affected in those tissues. In this case, it'll be ovarian tissues, causing cancerous growths or tumors. So your diagnostic criteria is that they'll do a bimanual palpation of your ovaries. They may do laparoscopic surgery to explore the cavity, and it's important to know where your ovaries lie. They are bilateral in the female body, so they'll open you up through the peritoneum, and they will obtain tissues for analysis through that area. As far as your laboratory studies, they may do cytological examination, and that's just looking at the epithelial cells, particularly in the ovaries, in order to determine what's going on, or if there's different tumors that are located within those ovarian cells. And they'll also do serum tumor marker levels. As far as your treatment, it is based on stage. Of course, you have different staging of cancer, and the higher the stage, the less treatable it is, or the more fatal it can be for that individual. So you may have multimodal therapies such as surgery, chemotherapy, radiation, and sometimes you may have one or the other, or you may have a combination of all three, just depending on how bad the stage is. Again, here's our pathophysiology. Some risk factors include family history. If you have the BRCA1 or 2 genes, there is a higher risk for you to have ovarian cancer, or even if you have a history of breast cancer that makes you susceptible to developing ovarian cancer at a later time. Environmental factors include ovarian trauma, such as with ovulation or use of hormone therapy. And then we have classifications of ovarian cancer. So not all ovarian cancers are the same. You may have germ cell ovarian cancer, sex cord ovarian cancer, and epithelial ovarian cancer. And of course, we have different stages. You may see one ovary affected versus the other one is not. You may see both ovaries affected. You may see the tumors extend into the pelvis. You may see metastasizing to not only the pelvic area, but the peritoneum, or the outside area of the pelvis. And then metastases, which is just those tumor cells traveling to other parts and organs within the body. So again, all of these would have a lot to do with ovarian cancer and how we label it and stage it. As far as your clinical manifestations, it's often asymptomatic in early stages, but you may see some bloating in your abdomen, and it's very vague. But once those tumors get big enough, they may manifest, or the clinical manifestations manifest as definitely pain, a lot of pain in the abdominal area, pressure, and distension. Next, we'll talk about menopause, and this is the cessation of ovarian activity. And it can be an alteration because sometimes menopause can happen earlier or later depending on the situation and the individual. But more oftentimes than not, it happens during ages 48 to 55 years old, and you have loss of trophic stimulation of your hormones. So your hormones are no longer working very well with your ovarian cycle, and that's with your follicular phase and your luteal phase. And then it causes atrophic changes of those reproductive organs. And when we talk about atrophy, that is the unusableness. It's not able to be used anymore. Those reproductive organs are starting to fade, and you more oftentimes see that with as a clinical symptom as well. With your diagnostic criteria, you have no periods for at least 12 months in absence of other causes, and that could be an absence of stress, like nothing can happen, you just don't have your menstrual cycle anymore. They'll do laboratory tests. They may see your serum follicular stimulating hormone increase, or they may see estradiol, which is a type of estrogen, and inhibin, which is another female hormone, decrease. As far as your treatment, you have hormone replacement, so they'll do both, multimodal. You'll see estrogen replacement and progesterone replacement. They may do selective estrogen receptor modalities, or they may even give you raloxifene, and this is to help prevent osteoporosis. When you have menopause, you have a higher chance of getting osteoporosis without this medication. As far as non-pharmacological methods, you want to avoid spicy foods, caffeine, and alcohol, so that'll lead a lot to your dietary changes. And you want to use a lot of exercise and relaxation techniques to help with menopause. So menopause is heavily associated with a loss of estrogen. Again, you have the cessation of your menstrual cycle, or amenorrhea. You may see a decline in your breast size, the elasticity of your skin, your body hair, and your subcutaneous fat decreases. You may see the atrophy of the ovaries and the uterus, so they're no longer usable. You may see the vaginal walls or the uterus thinning. You will see urinary urgency, even stress incontinence, or you may see dyspareunia. More severe symptoms include hot flashes and mood disorders. So you may see anxiety, mood lability, irritability, and even depression. Sleep disorders such as insomnia or disrupted sleep. You may see a decline in your libido or your sexual drive. You'll see bone loss, which is characterized as your osteoporosis. You'll see cardiovascular disease and fatigue. Next, we'll talk about erectile dysfunction, and this is the inability to achieve and or maintain an erection sufficient for satisfactory sexual performance. So there are different factors that affect erectile dysfunction, such as hormonal issues, neurological issues, vascular obstructions. You may have psychological issues that promote erectile dysfunction, such as low self-esteem, depression, and anxiety. You may have veno-occlusive abilities that are impaired, so you're not able, your veins and your circulatory system is not working very well in the area of the penis. And you may be on medications that prevent it, such as antihypertensives. As far as your diagnostic criteria, you have a history and physical examination, and your serum hormone levels include testosterone, luteinizing hormone, prolactin, and thyroid. So they'll look at those levels. And as far as treatment, you want to do psychosocial support, pharmacological treatment. One of the more common treatments is Viagra or sildenafil. They may, the Afils is your class that would support this. And you may even see penile implants for erectile dysfunction. As far as your clinical manifestation, it's just one thing, and it is the inability to achieve and maintain an erection. Benign prostatic hypertrophy, you'll see a lot of this. It's also known as BPH. And the cause is unknown. More oftentimes than not, you see it in the elderly or older population in males. So aging is the largest risk factor, and it is a reduction in your testosterone levels, and you'll see an increased proportion in estrogen and dihydrotestosterone, which is a precursor to testosterone, and it does lead to prostatic cell proliferation and growth. So When we talk about prostatic, this is the area of the prostate within males, but this is not a prostate cancer precursor. So you can have BPH in absence of prostate cancer. So they're not one and the same, but you can have BPH and prostate cancer. But just because you have BPH doesn't mean that you'll get prostate cancer. It's just something that happens in absence of that. So as far as your diagnostic criteria, males have to start getting a digital rectal examination, and that's normally starting at age 40 or so. And they'll also test your urine. They'll look at your prostate specific antigens. They may even biopsy the prostate just to make sure there's no tumors or anything growing. And then they'll use a diagnostic criteria according to the American Urological Association Symptoms Index. As far as treatment, you do have pharmacological methods to help treat BPH. One of those is tamsulosin. We also will see urethral stents. You may see a transurethral resection of the prostate if that prostate is too swollen. You may even see laser and heat-based treatments to destroy the prostate gland. So this is a multimodal approach. Sometimes people need a couple of these treatments in order to help with BPH. As far as your clinical manifestations, you have urinary frequency, dribbling, hesitancy, incontinence, urgency, and retention. So the next one we'll talk about is prostate cancer, and you can get prostate cancer with different risk factors. They are thinking that age is a major risk factor, so you see this more in the elderly population. If you're Black or have a family history of prostate cancer, you're more at risk to developing it. Smoking, and if you have a high-fat diet, you're also more prone to getting prostate cancer. There are genetical factors that are involved, environmental factors, hormonal factors, and sometimes the cause is even unknown. So you have an idiopathic pathophysiological cause there. So this one is also considered multifactorial and or idiopathic just based off of the different risk factors that are involved. As far as your diagnostic criteria, of course, you have to have a rectal digital examination. They'll do an ultrasound, transrectal ultrasound. They'll look at your prostate specific antigens. They'll biopsy the prostate. They'll also look at your pelvic lymph nodes and dissect those and see if they're swollen. They will also do a radionucleotide bone scan, and also they'll look at your tumor classification if you do have prostate cancer to stage it. As far as treatment, same thing as any other cancer, it's multimodal. So you may have chemotherapy, radiation therapy, surgery. There's androgen deprivation hormone therapy, and also watchful waiting. So prostate cancer can be deadly once it progresses and metastasizes. As far as your clinical manifestations, again, you have hesitancy, retention, urgency, incontinence, asymptomatic until advanced, and then you start seeing these symptoms, and you may even see urinary frequency. So the next one is testicular cancer, and this has an idiopathic cause. The cause is often unknown, but they do look at chromosome 14, and that may be one of the biggest implicators, but it's not been proven yet. And you'll see germ cell tumors such as seminomas or non-seminomas. As far as your diagnostic criteria, you have self-testicular exam, so that's where you're palpating yourself to see if there's any abnormalities. This is very similar to a breast exam. You may get your tumor markers pulled. You may even have an ultrasound, CT, an MRI done just to check and see if there's any tumors that are developing. And if they do see those tumors, then you may have a multimodal approach again. You may have surgery, radiation, and or chemotherapy to help treat testicular cancer. As far as your clinical manifestations, you may have a small painless testicular mass. You may see a slight enlargement of either testicle left or right, or maybe both, depending on how far the cancer has traveled. You may see a heaviness or enlargement of the scrotum, or you may have mild discomfort in the testicle. Okay, so this is a very short chapter for us, and although we're not going into terrible detail with chapter 14, I still want you to make sure you at least look at the guided learning questions on this chapter. Make sure you complete your disorder cards, look at case studies and the activities that we'll do. Make sure you review everything, the diagnostics, clinical manifestations, treatment, and application. Quiz yourself and quiz others. Answer the questions in your textbook, and reach out if you have any questions. Thank you, and I'll see you in class.